I was never happy to go to school. It's pretty miserable. Okay, non-fasting hypoglycemia. So, this side. It is broken down into organic or structural versus functional. There's a couple of things under each one of those that we can cover. So structural, I can't say that word, I can't speak for some reason, I'm like, oh, structural. There is a condition where it's alimentary, so GI, tract eating issues. This is due to rapid emptying of the gastric content to the small intestines, producing a rapid elevation of insulin, which then leads to hypoglycemia. This is something that can be seen after gastric bypass surgery. It is actually, I won't say a common thing, but it's something that individuals that have had gastric bypass or any, I know there's differences with the sleeve and the bypass and the band and all that jazz. Anybody that's manipulated that area in regard to processing or breaking down of food can have issues with this. So again, be mindful that if you have a patient that presents that has had that type of procedure. During your follow-up for gastric, that's one thing they look at is people who have had hypoglycemic events. They will ask them about that. I had a friend, a nurse that I worked with at Family Medicine who actually had gastric bypass surgery, and her doc actually sent her home with a glucometer and strips to test herself, to make sure, because it was such it was obviously an important enough thing that he did with all of his patients, I'll say that. So when we would be in clinic, she would be checking her blood sugar to make sure she was not hypoglycemic. So be mindful of that. Now, for this one in type 2 diabetics, in the early stages or early phases of type 2 diabetes, the first phase of insulin release is often lost, and the second phase is prolonged. It's thought that the delayed insulin secretory peak after glucose absorption causes hypoglycemia in the later stages following the meal. So type 2 diabetics, at first, and this is early in the disease state, they're able to, maintain for the most part. But after a while, especially if they're not controlling themselves appropriately, they just start to burn kind of everything out. And they're not able to even maintain. And there are different phases of insulin. So they lose one of those phases, and it can cause them to have a hypoglycemic event. So just be mindful of that. The bottom point is just treatment. So this would be some of the things that you would want to speak to me about. And again, the meal plan is so important with diabetics. I've already said that, but small meals. And then again, structural or organic, tons of different endocrine deficiencies. Ones we've already mentioned. Hypothyroidism is one. Issues with the adrenal gland, pituitary gland, the same stuff that we've already talked about. And again, the reason for that versus when we mentioned the endocrine issues in the other part, there are certain endocrine issues that only happen when they are postprandial, so they're not hypoglycemic all the time. It's only after they eat, and then it starts to rear its ugly head. So the functional one that you need to know about is idiopathic postprandial syndrome. Essentially, I just want you to know this definition of what this is. That's what I believe the lecture objective is just no definition. And the reason for that is this is a very confusing, very controversial syndrome. It's one that they go back and forth on in regard to what are the guidelines, what really causes it. It's kind of like what chronic fatigue syndrome was when it first came out. You know, everybody was like, well, it's real, it's not real. There was a lot of debate. Now we know chronic fatigue syndrome is very real, and there's guidelines and they actually treat it. This is how this is. Has anybody ever heard of idiopathic postprandial syndrome? Anybody know of anybody that has it or read about it or? It is confusing and it's frustrating because there's no real way to work it up. Of course, you're going to do a general workup, and we'll get to that in a minute. But again, they don't know what really is causing it. So what lab do you run? You run what you can to rule out the other things that you know cause hypoglycemia. Bless you, sir. The syndrome consists of a lot of the symptoms that we've already mentioned that go along with hypoglycemic events. Feeling lightheadedness, headache, dizziness, poor concentration, shaky. But it happens after they eat. Which one's postprandial, which is weird. I don't know though, I've actually done, have you ever eaten and then after you eat kind of feel weird, kind of like shaky, or it's a very odd sensation. One way they started to try to work with these people that they thought had this is they would give them an oral glucose tolerance test. When you see OGTT, that's what that means. So if you see that acronym, you'll understand it. One of the reasons why there's a lot of skepticism in regard to this is that they feel like doing an oral glucose tolerance test is not appropriate. I'm going to read this. Many healthy individuals have a very low glucose level at some point during an OGTT. Most people will. Without symptoms. The reverse happens often as well, as people often show symptoms during an OGTT without a documented low blood glucose. The meal usually given to treat these patients for postprandial hypoglycemia is the 5-hour oral glucose tolerance test, which usually they use 75 or 100 grams. It's usually 75 grams is the main one that most places that's what they use. And their biggest argument was, well, that's not really a meal. I mean, giving someone a load of 75 grams of syrupy sugar, it's not really a normal meal. And it's not the meal that causes symptoms in the first place. So what they started to do is they started to give them what's considered a mixed meal. So something more like you were to sit down and really eat a meal to try to elicit the symptoms. And what they found when they did this is their symptoms of hypoglycemia actually decreased significantly. So it was really due to that oral glucose challenge test. It wasn't appropriately working them up or diagnosing them for it. So a lot of individuals did away with doing a 5-hour oral glucose tolerance test to diagnose the people. And again, that's where the frustration comes into it with from a practitioner's point of view, is there is no real way to work them up other than going through your differential and doing all the tests that you know to identify things that cause hypoglycemia. One thing that they have found for this disease or syndrome, it's not a disease, it's a syndrome, is that again, dietary requirements are extremely important. We focus on refined carbohydrates, small meals, but even with that, they found individuals still have postprandial hypoglycemia or hypoglycemic events. Most of these patients are referred out. They refer them to nutritionalists. Internal medicine and endocrinology are the three biggies that they refer these people out to. Nutritionists for the dietary side of it. Internal med to look up comorbidities or chronic issues that may be affecting them. And then the endocrinology to look for any endocrinopathies that could be causing their hypoglycemia. So again, for idiopathic postprandial syndrome, you can go read about it all you want. I know you can't, do it. But again, there's just a lot of vague stuff about it. Just give me a general, just know the general idea, general definition of what it is. Please. That's all I would ask you, if I even asked you about it. Because again, it is so out there. But I did want to introduce you to that term, so you won't be completely lost the next time you hear it. So now we're going to do the diagnostic approach to your patients that have hypoglycemia. So again, this can be utilized for anyone that comes in that you're like, I need to work out for this. I need to figure out what's going on, if you want to take that on. So again, you have to have documented low glucose levels, symptoms when glucose levels are low, and evidence that they are relieved when they take in some type of food or sugar. By doing this diagnostic approach, you're going to be able to identify what type of hypoglycemia it is, hopefully. So, some of the tests that you want to do. Initial tests, you obviously want to do a blood glucose. You can order that. It's obviously included in a CMP, but you want to do a finger stick in office for sure. You can do a finger stick. It takes 2 seconds to do it. Your nurse can come in and do it for you. I got this from your Greenspan book. And it says less than 45, but honestly, again, don't focus on numbers because I told you, you have the 60, you have the 50, you have the 30. Don't focus on that. It again goes with symptoms. They have to have symptoms. But 45 is obviously low. Basically anything less than 70, in my opinion, is a low blood glucose. But again, they're just saying document a blood glucose. Get a blood glucose. Get a blood glucose. You can also do a plasma glucose overnight fasting. So if it is greater than, or 60 and below on 2 occasions, you have to have at least 2 occasions. It can't be just a one-time thing. That is going to help build your case for hypoglycemia. Then there's actually a 72-hour fasting. Because again, God, can you imagine fasting for 72 hours? Again, for most individuals, because of that reserve that you have, it should build into that reserve because you're like, well, my God, after 24 hours, you would just blot them out. Not really. No, I mean, if you have an appropriate storage, that 100 grams, it should keep you at a level. You may feel like, ugh, and shaky and weird, but it will keep you at a level. So you have to do the 72-hour fasting. This one is an inpatient. This is the one that I told you that the young lady was in. They put her inpatient because they did all this. And when you make people fast to that level, you do want them inpatient so you can monitor everything about them. Their heart rate, output, all those things. And you have to do blood draws a lot. You're going to go in there. So these folks, if you really thought somebody was hypoglycemic and you wanted to work them up for it, that would be an inpatient state. And you can put people inpatient for things of this nature. You can also get a hemoglobin A1C on them. Low hemoglobin A1Cs are also concerning. We don't see a lot of those because all we ever deal with is the high end of it. But you can order a hemoglobin A1C. This would be concerning for if you had type 1 diabetics or for people who were chronic hypoglycemics. They would have a low hemoglobin A1C. You would want to order a CMP on them because you would want to look at their liver function. I didn't put this on here, but also the renal function. Because like we mentioned earlier, there are some instances where liver disease, liver insults, and renal insufficiency can cause issues with hypoglycemia, right? So you'd want to get a CMP on it. Your CMP also has a glucose on it as well. So those are your kind of initial tests that you would probably want to run on everyone. So finger stick, whichever one you want to do, your overnight fasting, if you want to do a 24-72. The literature shows a lot of people do the 72-hour one because 24 just doesn't seem, they can kind of miss things. They do the 72. Get a hemoglobin A1C on them and then get a CMP on them. It's not in here, but I'd also get a CBC because you're alcoholics. If you thought alcohol, you would pick up some weird stuff on their CMP, but alcoholics have oddities on their hemoglobin and hematocrit. So get a CBC as well. So that's your initial workup, things you want to get. Additional tests that you can get on individuals, a C-peptide measurement, I would get that for sure as well. That's an easy thing, I've actually ordered that before. Your C-peptide, what is your C-peptide? What is that?
The byproduct.
Okay, right, so obviously you can see why that would be an important thing. Because if you're like, is it low insulin? Is it high insulin? Where are we at with this? You want to look at your insulin level because that's going to help you differentiate even further where you're at. So get a C-peptide level on them. You can actually also order a serum insulin level. And it's important to note that if you get in a certain range with your glucose, your insulin should be suppressed. So if you know you're having a person in a fasting state, when you check them and you get to a number, you know insulin should be low. But if you get the insulin and it's high, not where it should be, and I put numbers in the notes section for you to read, you know that's inappropriate. Your insulin is not where it should be. So C-peptide, get a serum insulin on them. They also have what's called an insulin radio immune assay. And that basically just looks at insulin for tumor type stuff, also for autoimmune type diseases. That is a pretty specific test. That'd probably be somebody specialized in that area. But as a primary care person or family medicine approach, you absolutely can order the first slide, that's the previous slide, and the C-peptide and the serum insulin very easily to work up your patients. If you thought there was an endocrine issue, you're obviously going to order what tests you would do for those disease states. So if you thought Addison's disease, we've already covered that. You know what you would order for that. I'm not trying to not put it in here, but we've already covered that. You can go look at that slide. Thyroid as well. thyroid panel. In regard to C-peptide levels, they would be elevated in the following things. So these are again hypoglycemic, excuse me, states that I've mentioned previously. But this helps you differentiate maybe down a little bit further if your C-peptide came back elevated. So an insulinoma has a high C-peptide level, which obviously you understand why that would be, right? Yeah. Sulfonylurea intoxication. There are certain syndromes, the NIPHS, which I'm not going to lie to you, I've never even heard of that until I put this lecture together. I'm sure in an endocrinopathy world that's probably pretty big. They know about it more. They can also have high C-peptide levels. Insulin resistant states, so obesity, which more importantly, what else would be included in that kind of obesity you should have got it in your OB-GYN course? Yeah, PCOS, you can also, yeah, absolutely. Because you know, they start to become insulin resistant as well. Cushing syndrome. And then chronic kidney disease. And again, I don't want to, you know, this lecture would be 5 hours long. You can read on the pathophysiology of those states and why that would be for the C-peptide. But kidney disease is just because you don't filter anything out anymore. So everything starts to bump up in the blood. They're suppressed or low in these disease states, syndromes, or events. Type 1, why exogenous insulin injection? Right, it's not it's a synthetic form, so, which the gentleman that was injecting himself that I told you about, the attending that was on service with me, his name's Dr. Mole, he's maybe one of the smartest men I've ever met in my life. He drew those on him, he drew a C-peptide, and he knew he was doing it to himself because his was not there, it was non-existent. Insulin-like growth factor secreting tumor, it's not going to give off the C-peptide like it would from endogenous appropriate insulin production. And then, of course, insulin-independent hypoglycemia. So hypoglycemia from other issues that we've mentioned. There is a special test, I mentioned it in the 2-3 slides up. This is better description of how you do the 72-hour fasting for you to read. And better, if you're like me, I like to know exactly how something is, I can memorize it better. So this tells you how and what's administered, the time periods that you actually check, and what blood levels you draw and what they should be. And you can read that because I've already mentioned it, but read it. It's provocative because you are you're suppressing, but that you're also administering, because you want to see if you can get something to a certain level. But you can read that. It's essentially the 72-hour. This is interpretation of the results. I would not write a question that had numbers that you would need to memorize. So again, this is just for you to read and better understand this test. Or use it, review it when you go on your rotations. You need to come back and look at it. We have an endocrine rotation. You guys can go on if you want. So this would be important for that. So like I told you earlier, the diagnosis of an insulinoma I will cover at the end of the lecture. So here it is. You have to know how to diagnose an insulinoma. So please, what's in red is very important. So obviously you're going to have a high insulin level because it's secreting insulin, coexisting with a clearly low glucose level. And that immunoassay that the insulin assay that I mentioned earlier, it cannot differentiate between your exogenous and endogenous. It doesn't go that far. It just looks at other markers. So you have to get a C-peptide with it to determine if it's endogenous or being taken from outside into the body. So you have to get a C-peptide to distinguish it for your hyperinsulinemia. It will be high. Your C-peptide will be high. So no, high insulin level, low glucose level, and a high C-peptide. I wrote those 3 things out for you in the notes section. That's what you need to know in regard for working up an insulinoma. And those are the 3 tests you actually order. I mean, of course, other things. But that's not, I'm not just trying to get you to memorize this to pass your test, even though it's important. This is applicable in real life. I mean, this is how they do it. So high insulin level, low glucose, and a high C-peptide. Please know that. You can get a proinsulin. That's another test that people will order. You've probably been introduced to that thus far in your other lectures. Anyway. We'll get this. The last bullet point, I won't ask you about proinsulin for the insulinomas, but that is important because they are inefficient producers of insulin because, again, they produce and release a lot at an abnormal rate. And the proinsulin level is abnormally high in relation to what you would normally release. So what they do is you can actually get a ratio. You can do a pro-insulin to insulin ratio and look at the abnormality there to help also confirm or determine it. We've got some sneezing going on. But it's usually the ratio is greater than 30%. But again, I only want you to know the 3 things that I told you. But again, these are all real things you would do. These are all applicable. Of course, since it is a tumor, you do have to go and look for it. Different ways that you can do it. The lady that we had, they started her out with a ultrasound. Because again, ultrasounds are very cheap, easy, quick, and there are no radiation to them involved. So they started out with an ultrasound of her pancreas. But they ended up having to actually do a CT scan because they had to go in and do a biopsy of it. And they wanted to localize it because she was going to have surgery. So they followed up with a CT scan to get better measurements. But they did start with an ultrasound. So it's applicable. You can read this on your own. These are just some of the other ways that they do it. They can do angiography. And again, that's just real time where they sit there and they watch it when they inject the dye to see. You can also do arterial calcium stimulation. And then there are instances where they do intraoperative ultrasound. if they need to actually open somebody up and they get in there, they want to identify more components of it, to make sure they get it all, you can actually also do that. But that's a little specialized, you need to know that you can start out with a basic ultrasound and then move to CT or MRI. Is there any questions over that? I know it's kind of all over, yes ma'am.
Is an insulinoma the same thing as the insulin-like growth factor secreting tumor? Is that the same type of tumor?
No. Because IGF-1, there are different endocrine tumors that can secrete the insulin growth factor 1, different ones.
So because it had that suppressed C-peptide, so that's like an IGF tumor suppresses the C-peptide, but an insulinoma would make it higher?
An insulin, no, they're different because insulin is insulin. Insulin's going to secrete, because of the high amounts of insulin, when it cleaves, it's going to have a high amount of the C-peptide. But the IG, that's a different one in that it doesn't secrete it to the level of an insulinoma.
So an insulinoma is like legit same insulin that you would get?
Yes,
Okay.
not so much what you give yourself. 'Cause
Right, but what your body
Yes,
is.
yes,
Okay,
maybe,
okay,
yes.
okay.
Because again, because the other one, it can be in other areas, and it's actually, it's usually secreted with tumors like in the small lung cell, the ovarian one. The small lung cell is the biggest one that secretes that.
Okay.
The insulinoma is particularly in the beta, it's in the pancreas. So it's like overproducing from, and it's the insulin that we all get to regulate ourselves. That's a great question. Any other questions, guys? Anything about that or any of the lectures I've given?
So you were saying that tumors that outside of insulinoma that secrete insulin, the insulin's going to look different than our normal endogenous insulin, is that correct? Because I was trying to figure out, if you had a tumor that was producing insulin, how would you differentiate whether it was an insulinoma or just another tumor or cancer that is producing insulin somewhere else in the body?
They'll have co-occurring with it. It's also a clinical picture because if it's a metastatic or some type of other funky tumor, like small cell or ovarian, you're actually going to have other things going along with that. And they also secrete other things that are endocrine related. But an insulinoma is very specific to, well, one, the location of it, but also the amount of insulin that it puts out is not to the same level as those other tumors. Because again, those other tumors secrete a bunch of other funky stuff. Insulinoma it's insulinoma, insulin, that's all it does. So it's extremely high, and the C-peptide is really high, as opposed to the other ones. Now, I'll be honest with you, I don't know to what level those other tumors secrete in regard to the insulin, but it's not to the same level of the insulinoma. It's like the Mac Daddy of insulin secretion, because it's the primary thing that it secretes. Does that answer your question? So labs would help you differentiate. Location, obviously, if you were thinking insulinoma, pancreas location, because again, 90% of them are in the pancreas. That's where those other tumors that secrete insulin or other weird stuff, cortisol, ACTH, they're going to be located in the lungs, the ovaries, the pituitaries. The location, lab values, and also symptoms would help you differentiate it down and get more into insulinoma. Because with those other tumors, they're going to have symptoms that go along with those locations and disease states. I hope that. Bless you. Great questions. Anything else, guys? I'll submit to Dr. Latassi 7 to 8 questions. That's what they ask for each lecture. I've already submitted all these questions. And I know you guys saw that email, but she didn't put all the questions that I wrote for your first exam. I just said 8. She used some for your first exam.